You're listening to Heart-to-Heart Conversations, an unscripted discussion on today's hottest topics in interventional cardiology, with your host, Dejan Milasinovic. This podcast is brought to you by PCR.
Hello, everyone. I would like to welcome you again to another edition of Heart-to-Heart Conversations. It is a program which we have designed with a deliberate intent to provide to you live and heart-to-heart discussions, an honest discussion about hot topics in interventional cardiology. This time, we have invited and are very thankful to Professor Ole De Backer for joining us for a discussion about a topic which concerns the interventional community. It's the bicuspid aortic disease. Welcome, Professor Ole De Backer. Thank you for joining us.
Thank you, Dejan. Thank you for the introduction.
So the idea today was that we speak about TAVI in bicuspid aortic stenosis. But what is the angle that we are going to take with this subject? It's fairly an emerging subject and an emerging problem in patients who we treat with transcatheter aortic valve implantation. And we have decided to tackle this problem from two sides. Let us speak about the evidence. So when should we, based on the current evidence, accept these patients and treat them with TAVI? And if we decide to go along with TAVI in these kinds of patients, what is the best practice? And these two major topics we are going to discuss today with Ole. That being said, I would like to ask Ole, why is TAVI in bicuspid aortic disease a question at all? Is it relevant? I mean, how often, how frequent is it encountered across the globe? Is it something which is relevant for TAVI practice?
Yes, thank you for this introduction to the topic, Dejan. I mean, definitely, I would say, of course, it's relevant. This is not just a niche of TAVI. I mean, even, I would say, first, if you look worldwide, I mean, we have the West and the non-West. If you look to Asia, for example, where TAVI and bicuspids is almost representing half of their cases. If we looked into our own practice in the West, I would say, even to my own practice, last year, 16%, so almost 1 out of 5 cases were TAVI to treat bicuspid aortic stenosis. So, and the more we move into the younger patients, the more we know that bicuspid aortic stenosis is prevalent. So definitely, I would say it's a very prevalent, it's a very relevant topic that should be discussed, and it will become more and more relevant as we move into the younger population.
Yeah, you said it rightly. There is a tendency to treat younger and younger patients with a transcatheter approach. Now, the question is, what evidence do we have at present to base our decisions on? I mean, the low-risk trials, can you describe to us and to the audience what low-risk trials we have so far? That means in younger patients as well. And how do they inform us on the issue of bicuspid disease?
Well, unfortunately, if we look to the body of evidence we have for TAVI and bicuspids, it's really poor, yes. I mean, we know the low-risk trials. These were perfectly conducted trials, like Partner 3, Evolut Low Risk. We had some other trials like Dedicate, the original Notion trial. So all these trials were kind of low-risk trials. But what they did is they excluded all bicuspid patients. So that makes that actually up to today, we didn't have any randomized trial data on comparing TAVI with surgery in bicuspid patients. So we don't have any, except for a small subpopulation of the Notion 2 trial, which was conducted indeed in the Northern Europe, and only a subgroup of 100 patients were bicuspid patients, and that gives a small glimpse of some comparative data, TAVI versus surgery. But otherwise, all the data we have so far are, most of the time, they are all retrospective, from retrospective registries. So this is, of course, very, we have to be very cautious about patient selection bias there. And typically there are not comparative TAVI versus surgery. They are single arm, just reporting the data of TAVI and bicuspid, or sometimes they are comparing data bicuspid versus tricuspid.
So just to reemphasize, I think it's important what you said. So basically, we started off saying this is not a niche indication. In your everyday practice, it's 16%. It's close to 20% of patients with bicuspid disease being treated with TAVI. This contrasts actually with the present evidence base, where we have 4 low-risk trials, starting with the original Notion trial, Evolute Low Risk, Partner 3, and Dedicate. All of them did not really include the bicuspid patients. So that's where we are at, or where we were at in 2023. Now, in 2024, there was a trial called Notion 2, of which you were the PI, and this was the first trial to include bicuspid as part of the low-risk population. Can you tell us more about the Notion 2 trial, and what is your take on the trial as lead investigator, and what are the main messages, the design and the main messages?
Yeah, so very simple. Notion 2 was actually targeting the younger patients, younger, low-risk patients, so meaning the whole population was between 60 and 75 years of age, yes? So younger patients, especially for the European context, and then they were also low risk. And what we did is we randomized in TAVI versus surgery. Of course, we wanted to be as open and have an all-comers population as much as possible. So we did not exclude bicuspid patients. We did not exclude patients with, for example, concomitant coronary artery disease. So what is interesting in the overall trial, we missed a little bit power for the primary endpoint of mortality, stroke, and rehospitalization related to the valve, procedure, or heart failure. But what was interesting looking into this, what you now just also show in a way that looking into the sub-analysis for tricuspid comparing to bicuspid, we saw that the TAVI and surgical outcomes were almost 1-to-1 in the tricuspid arm. Yes, so there are no signs. Again, we have to be careful. These are only up to 1 year follow-up outcomes, so kind of short-term outcomes. It doesn't say anything on the long-term outcomes because that's still an all other story. Also there, by the way, we don't have any data in literature beyond 2 years of TAVI and bicuspid. Believe it or not, we're doing already quite for some years in many centers worldwide, TAVI and bicuspid. We don't have any data of TAVI durability beyond 2 years. So going back to Notion 2, tricuspid looked very promising. On the other hand, bicuspid, the patients, I have to warn there again, it's only a very small group of patients, 100 patients, 50 to TAVI, 50 to surgery, but there were clearly more events, clear worse outcomes like stroke. We had a couple of strokes. We had 2 mortalities in the TAVI arm versus excellent, truly excellent data in these young, robust bicuspid patients.
Yeah, so when you think about a Notion 2 trial, I think saying that the mean age was about 70, 71, it was basically, I think, younger than the Evolute Low Risk and also younger than the Partner 3 trials. And then in that population, you found close to 30%, 27%, a quarter of patients having bicuspid disease. So I think this says very much about what you just said. It's not going to be a niche indication. It already isn't, but it's not going to be at all once we move into this younger, low-risk populations, which seems to be the tendency. Now, thinking about the results, what I would like to ask you is, in terms of the mortality, we did not see any difference in the first year. In terms of rehospitalizations, also no real difference. In terms of bleeding, major bleeding, and atrial fibrillation, there was a better, statistically, actually significantly better result with TAVI as opposed to surgery. However, what we could see was that the rate of moderate or more than moderate paravertebral regurgitation was actually more frequent with TAVI, both in tricuspid and bicuspid subsets. And as you said, stroke was a higher rate in the bicuspid disease in the TAVI arm. So surgery was better there. So what I would like to ask you is the first question, what about the PVL? What is your interpretation of the data on PVL? And then the second, what is your interpretation of the stroke data? And let us discuss it a bit more as well.
Yeah, so first you want to start with PVL, paravalvular leak. Look, I mean, of course, in the surgical group, we have excellent surgical centers here in Northern Europe. It's very big volume. So there was actually 0 PVL in all the patients, in the surgical patients, so 0% there. We had in the tricuspid patients treated with TAVI around 3% of moderate PVL, which is in line with all the other literature, so very low acceptable rates. If we went to look into the bicuspid patients, again, this is a non-selected, unselected bicuspid group. It was not selected to be eligible or not. There was no assessment eligibility committee for this trial. We had up to 8% of moderate PVL in the TAVI patients with a bicuspid anatomy. So clearly there was higher incidence of moderate PVL. Looking then to the stroke, well, there was in the entire population, there was more stroke than in the surgical arm, which was a little bit surprising. This was driven by two facts. First, it was driven by more peri-procedural strokes in precisely these bicuspid patients. So bicuspid patients treated with TAVI, maybe we have to be a bit more cautious there about the stroke risk. And then secondly, we saw, surprisingly also, we saw some late strokes in between the 3-month and 1-year follow-up period. But this was, by surprise, not really seen in the bicuspid patients, but this was actually more in the just regular tricuspid patients treated with TAVI. And we just did actually a root cause analysis there, and this has related to underexpanded valves. Now, I think it's just by coincidence that this was in tricuspid patients in our study, but if you zoom a little bit out, the issue of underexpansion of transcatheter aortic valves becomes more, we become more and more aware that this is a risk factor for maybe late stroke or underperformance of these valves, maybe earlier degeneration or bad hemodynamic performance of these valves on the short to medium term already.
Okay, so if we zoom out, my interpretation of what you said is that the PVL rates and the strokes might be preventable, because if they're associated with how we proceed with the TAVI, if they're associated with how we actually do the procedural steps, then we can do something about it. Even the later ones, so you said there was a half of strokes that could not be tied to the immediate peri-procedural period, but happened later on. But if you looked at them closely, they happened in those patients where the wall was not expanding well. So these all seem to be preventable events. So we can improve the prognosis of bicuspid patients or overall TAVI patients by adequate or optimal implantation. That being said, I just want to remind everybody, and we are being streamed live on YouTube, on Twitter, X today, Facebook, LinkedIn, and other networks. So please join us with your questions. You can ask questions from the PCR Online website in a most easy way. So please do that. We are happy to respond to them. My question to you, wrapping up this first part, bicuspid TAVI seems not to be a niche indication today based on what we see in everyday practice and what you said from your everyday practice. That being said, we do not have direct randomized trials in that very subset. The first data, which comes from a randomized trial, which is an Ocean 2 trial, is also in effect not directly a randomization. It is a subpopulation of a randomized trial. So the evidence is not enough, but we do see signals that there is a risk of higher stroke rates, and there is a risk of higher, moderate, and severe paravalvular regurgitation rates. That all being said, when do you decide to perform TAVI in a bicuspid anatomy? Which patients?
Yeah, which patients to accept for TAVI? Well, I think that's, of course, you have to make an assessment of your patient, and I think it's multifactorial. It's not only looking to the surgical risk, as the guidelines are very unidimensional. Yes, the guidelines say something about age, they say something about surgical risk / comorbidities of your patients. But I think what we learned from Notion 2 especially is that it's not only sufficient to look to your clinical characteristics of your patient or your surgical risk, but you should also really look systematically to the anatomical, the anatomy of the aortic stenosis and the anatomical features of that patient. So again, having said that, then from my side, I mean, I think that means that if you want to do a proper assessment of your patient and good decision whether you want to treat him with TAVI or with surgery, that craves that you have a cardiac CT, yes, at your heart team meeting. And I think more and more heart teams worldwide start to adopt this, that you have on all patients discussed, especially also these younger patients, because now in many centers still only the older patients which are probably going to TAVI, they get a cardiac CT. But I think it should be also done for the younger patients, because there it's even more important. So to get to know the anatomy, the underlying of the anatomy, and then you can make a real decision on whether this patient is eligible for TAVI or maybe more eligible for surgery. For example, if it's a patient with a very, very small annulus, then this is maybe more favoring TAVI than surgery, where you have more risk for patient prosthesis mismatch. Whereas if I have a 75 or 72-year-old patient who really wants himself TAVI, but I see on my cardiac CT, he has a bicuspid anatomy with slightly dilated ascending aorta, with excessive leaflet calcification, with a very long calcified TAVI, where I cannot guarantee this patient an excellent outcome with maybe risk for moderate PVL, maybe even worse so if there's also calcium in the LVOT, maybe annulus rupture, or even other complications, then I maybe want to convince this patient that maybe surgery is better for him. So I think you have the clinical characteristics to look at, comorbidities, but especially we have to get to become better to estimate the risks on cardiac CT, the anatomical risk factors.
So my take of what you said is that if we have a low-risk bicuspid anatomy patient, if we want to proceed with TAVI, we need to make sure that a good quality optimal results TAVI is feasible based on the underlying anatomy, which we can analyze in advance. So my question to you is, how would you say that the bicuspid anatomy is different from the tricuspid in the sense of important procedural points?
Yeah, look, I mean, bicuspid patients are can be very different from tricuspid anatomy indeed. First of all, sometimes these anatomies, they have larger aortic annuli. That's one thing, not always, but they can have very large aortic annuli. They have typically more severe leaflet calcification, or sometimes more asymmetrical distribution of this calcification, especially younger patients with bicuspid anatomy. They have sometimes excessive leaflet calcification. So this is more difficult to tackle. There is, in the type 1s, there is a raphe. Very often this is also calcified, which gives additional complexity. Then we have not even talked about the aorta, which is also very often comes with additional risks. It can be a dilated aortic root. It can be also that there is a dilated ascending aorta in general. So what to do there if you have borderline dimensions for aortic root replacement, yes or no? What about coarctatio aorta? We have to screen for that too. This gives also additional risk factors doing TAVI. So you see the anatomy of a bicuspid patient can differ in many aspects from tricuspid patients with tricuspid aortic stenosis.
Okay, so the question is, when you analyze the anatomy in advance, how is it that you make your decision based on A, the feasibility of the TAVI in that patient, and B, how do you select the appropriate valve in terms of size, but also in terms of the valve choice?
Yeah, that's of course a difficult one. I mean, valve choice, valve sizing. I mean, you can talk about this for hours, to be honest. I mean, first of all, you need to do a very meticulous CT analysis. Yes, you have to do really not only look to your aortic annulus and maybe one or two additional measurements, LVOT, ST junction. No, you have to do really a meticulous analysis, scroll up and down through your CT to get a real understanding of the calcifications, the calcium distribution. And you also, by that, you want to estimate kind of a risk of this procedure. Is there a risk of annulus rupture? Is there a risk for a valve malpositioning where one or the other valve, or higher paravalvular leak risk? So these are all risk factors you have to estimate on the CT. And then I would say, which valve is better? That's always difficult. I think you have to, first of all, you have to look to the experience you have yourself. Yes, some sites have more experience with balloon expandable, others with self-expanding. So it's also, you have to make yourself used to a particular, maybe one or two valves to tackle particular anatomies. That's even as important as the valve type itself. And then there are the sizing methodologies. Again, this is typically best with an integrative approach. It's not one particular measurement that will guide you to a specific valve size, transcatheter aortic valve size choice. It's integrative, so you have to look to aortic annulus, you have to look to sinus of Valsalva, STJ, LVOT, the classical dimensions or measurements. But on top of that, there are kind of 6 additional bicuspid-specific sizing methodologies. Very brief. First, you have from the BAVAR trial. This is led by Didier Chiche. He came up with this idea of that the valve is actually anchoring and sealing higher up, not necessarily at the annulus level, but typically a little bit higher at 4 millimeter height. So he proposed to measure the intercommissural distance, the distance from commissure to commissure, and that gives some kind of a good understanding of how that landing zone is. Is it tubular, flared, tapered? And based on that, you can actually have reasons to downsize, yes or no. It is a minority of cases with a tapered anatomy, meaning that if the intercommissural distance is really smaller than the annulus mean diameter, you typically have a tapered anatomy or morphology, and then you would go for intercommissural distance sizing, as they call it, which would mean you go for downsizing of your valve. So this is one sizing methodology. The second one is supraannular sizing. Some people like to measure, do some tracing of around to guess a little bit what to anticipate what the final transcatheter aortic valve diameter would be. You can do this tracing, supraannular tracing at 4 millimeters height, which Didier Chiche also proposes, or you can do this at 10 millimeters height, the LIRA method by an Italian group proposed. You can also have a third sizing methodology, is the circle methods, where you can, especially for balloon expandable valve implantations, where you kind of simulate a circle into your anatomy and you scroll up and down and see if this circle kind of nicely matches, is not too large, not too small. And then based on that, you go for your balloon expandable valve sizing. Another algorithm proposed by Sonia Petronio from Pisa in Italy, she proposed the Casper algorithm, which is already it adds on the annulus dimensions, plus looking at, is there a raphe, is there a calcified raphe, how much calcification is there. Then she corrects for the sizing and subtracts 0.5 millimeter or millimeter respectively. So these are all kind of measurements you can do yourself on the CT. And then besides this, there is a 5th and 6th sizing methodology. The 5th is sending your CT to a specialized software company who can make computational modeling models and simulations. We have like FEOPS and DASI doing this. And this is actually a field which is expanding and growing. And maybe this is the way to go in the future, where these simulations become really good and predictive models, where we can predict the risk of annulus rupture or the risk of moderate to severe paravalvular leak or the risk of pacemaker, then we could be guided as an operator up front in maybe it's better to go for this valve type or this valve size at this particular height or depth implantation. So this is some work in progress. And the last one, sizing methodology, is more the old-fashioned sizing methodology, but still sometimes relevant, I would say, is balloon sizing. Yes, even me or my colleague having experience in hundreds of bicuspid valves treating with TAVI, we sometimes still are a little bit in doubt. We are in a gray zone. And then the conclusion is still, well, let's do balloon sizing. And that means, of course, it's intraprocedural, where we inflate a balloon. We fast-pace inflate the balloon, give some contrast, and see if it seals. So that's I
like that one, to be honest, Ole. That one sounds very simple to me. Out of the 6 that you mentioned, the balloon sizing one is the most. But, the computational modeling, that being said, the computational modeling is very appealing. If you could create a model for every single patient individually to describe their anatomy, that I think would really be a step forward into a patient-tailored medicine, a really individualized decision making.
Yes, exactly. Well, the only drawback from the balloon sizing, if I have to say name a balloon size, then it's intraprocedural. So you have to wait until you inflated your balloon and did your contrast injection before you can open up your valve and load it. So in the worst case scenario, patient becomes hemodynamically unstable in these couple of minutes, but luckily that's rare. But there are some drawbacks from this approach, of course.
Of course. Now, when we go and we will wrap up with that. Now, you've decided that you're going to perform TAVI in a bicuspid patient. Mm-hmm. You've seen the anatomy. You went through these algorithms. You picked your valve. and you are now faced with a procedure. What do you see as the crucial steps in the procedure to ensure that what we have seen in the registries and in the Notion 2 trial, and that is the risk of stroke, which may be associated with the valve under expansion as well, and the increased risk of PVL? How do you procedurally make sure that these two events do not occur in an individual patient?
Yeah. Well, look, very simple. I would like to picture it as such. If I treat a bicuspid valve, a severely calcified bicuspid valve, in my practice with TAVI, I have the same mindset as you should have the same mindset as you would do a coronary PCI on a very calcified lesion. So what do you do if you have to do percutaneous coronary intervention or a very calcified coronary lesion? First of all, you're going to go predilate, yes. The same for TAVI in a severely calcified bicuspid. You will predilate. Secondly, you do your valve implant in a proper position. And thirdly, you will go for pulse dilatation. Yes, you will not leave this valve behind underexpanded. And I think this is a bit how I think about TAVI and bicuspid. So I need a proper good predil. I need to do a proper valve choice, type and size. And then it's up to me as an implanter to know how to implant these valves. Typically, it means in average that you implant relatively high these valves, both for balloon expandable and self-expanding valves. You implant these valves slightly higher, maybe 2 millimeters higher than in the tricuspid anatomy. That's shortcutted set. And then again, you have to screen for valve under expansion. And most of the time, the valve will be under expanded, to be honest, in a bicuspid anatomy. Yes. Because it's elliptical, it's more calcified. There is even a very recent nice paper from the Cedars-Sinai group led by Raj Makar, which shows that in young bicuspid patients, even with balloon expandable valves, yes, these are valves implanted with a balloon, but that there is systematically more under expansion. And if you have under expansion and more eccentricity of these valves, that these valves have much more risk for leaflet thickening, leaflet thrombosis, and also clinical events down the line. Yes, so that shows again that it's imperative, it's mandatory really to pulse dilate, I think, and to do everything to kind of circularize and optimize the laminarity of your flow. That's actually what we do if we do TAVI. Yeah, we want to replace the valve, but ideally what we want is we want to restore the laminar flow over that valve. Yes, we don't want, if we leave a valve behind underexpanded, elliptical, there is still a turbulent flow. Yes. And the turbulent flow will stress the leaflets, may result in reduced valve durability. It will lead to more risk of leaflet thickening, leaflet thrombosis, maybe even more turbulent flow, less good washout of the sinuses, so also more thrombogenic there. So you see, there's a lot of reasons to pulse dilate, I think, TAVI and bicuspid, and we need, of course, evidence for this, but this is based on experience and the first glimpses of data coming out on this topic.
So, whereas when we perform TAVI in the tricuspid patients, it's not always necessary to predilate and or postdilate. Is it your standard practice, what you're saying, that in a bicuspid, you will always predilate and always postdilate?
Yes, indeed.
Okay.
And the predilatation is absolutely valid for every platform, self-expanding 100%, balloon expandable actually as well. I will do my valve implantation. And then, of course, you let yourself guide by, is there PVL? Is there good hemodynamics? That's your first reflex as an operator. But I think, as I said, you have to screen for under expansion. That means you have to look in orthogonal views. It's not just enough to look in your LAO view and say, yeah, it's well expanded. No, you have to look actually you can predict this from your CT. Yes, you can know what your commissural view is. Like if you have a right-left fusion, type 1 bicuspid, you will look into the minor axis of your valve from a right-left cuspovula view. If you have a type 1 right non-fusion type, then you have to go to look in an LAO cranial from a right non-cuspovula view to see if your valve is constrained. And I bet in 90% of your cases, your valve will be constrained after implantation. And then you will feel the need to go for pulse dilatation just to optimize these outcomes as I mentioned earlier.
Thank you for this. This is very useful. As we're coming to an end, one last question regarding the procedure. We've seen that the stroke is an issue. Is embolic protection a must for bicuspid? Is it something which you perform routinely for bicuspid disease?
But look, there we don't have data, unfortunately. Yes, we don't have the evidence to back us up on this. But in my own practice, yes, I mean, it all depends also, it's a big economical factor there as well. But if I go into a very calcified environment with my TAVI, I typically are going to use cerebral protection, yes.
Thank you very much. So if I may summarize, to our questions, when and how, your replies were very direct and very clear. You go for TAVI in a bicuspid disease patient only if you have, let's say, a view that you're going to be able to perform an optimal procedure based on the analysis of the anatomy, coupled, of course, with the clinical factors. And when we speak about the essential steps, looking for a potential underexpansion, which is really a threat and a risk in a bicuspid case, should be meticulous and, if possible, of course, corrected. Thank you very much, Ole. It was really a pleasure. Thank you all for joining us, and I hope to see you here soon. Thank you.
Thank you, Dan. Bye-bye.
Thank you for listening to this heart-to-heart conversation. Find out more about upcoming dates and replays of recent conversations on pcronline.com.